Hi, welcome back. So you're taking care of two patients. One patient is burning up. Their heart's racing, they appear agitated, and it looks as if they're headed towards cardiac collapse. But then you have another patient, and that second patient, they're shutting down. They're cold, slow, barely responsive. And know that both involve the thyroid, but they're completely different, total opposites. And if you miss the difference, you really can miss a life-threatening emergency with your patient. So today, I'm going to make thyroid storm and myxedema coma finally make some sense. So you can recognize it, answer those NCLEX questions, and know what to do as a nurse when you're on the floor. Um, so welcome to Nurse Ed Scholar, where we don't memorize, we understand. Okay. This is part of my endocrine critical series. And today we're breaking down, like I said, thyroid storm versus myxedema coma. So let's simplify it. So everything comes down to one thing, thyroid hormone. So you have your T3 and your T4. Okay. Now these hormones control the metabolism. And here's the key. Thyroid storm means there's too much thyroid hormone. Storm, just think of a storm. It's just so much stuff, right? Just so many things going on in a storm. And then myxedema coma, there's too little thyroid hormone. So think of coma. What do you think of? You think of a person in a coma is just laying still, like no movement, nothing's going on. So hopefully that helps. So storm, high, just too much hormone, thyroid hormone. Coma, low, too little thyroid hormone. And that affects the entire system, every system, and the entire body. It affects every system in the body. So let's look at the differences. Thyroid storm, severe hyperthyroidism. The body is overstimulated. Think of storm, like I said, it's just too much. So the body is overstimulated. Everything is going fast. On the other hand, myxedema coma, everything is slowing down. There's severe hypothyroidism. Everything is going slow. So let's think about it. Thyroid storm, fast and hot. And we'll talk about hot, because the body's stimulated. So when the metabolism revs up, it gets hot. So that's where the hot comes from. So fast and hot. And then myxedema coma is cold and slow. So you have too little thyroid hormone with myxedema, and your body's not stimulated. So the metabolism is slowing down. It's cold. So that's where slow and cold comes from with myxedema coma. And hopefully that one phrase, will help save you on exams. Now, let's look at some labs. TSH is thyroid stimulating hormone. So, with a thyroid storm, this is an acute life-threatening condition which occurs in a patient with uncontrollable hyperthyroidism. So, the T3, T4 is high because there's a hypersecretion of these hormones, and it causes that increased rate of the body's metabolism. Thyroid storm is usually caused by Graves' disease. Now, you'll notice that the TSH, that thyroid stimulating hormone, is low. But think about it. It should be. If you have too much thyroid hormone, the T3, the T4, why should the TSH be high? Think about it. Thyroid stimulating. It stimulates the body to make the thyroid hormone, but it doesn't need to because there's too much in the system. Okay. Myxedema coma, though, has a low T3, T4. So there is a hyposecretion of the thyroid hormone. And this causes the body's metabolism to decrease. And this is typically caused by dysfunction of the thyroid gland. Now, when you look at this, that TSH, that thyroid stimulating hormone, is high because there's not enough thyroid hormone circulating in the body So the body's like, produce thyroid hormone, produce, produce. So that's why that TSH is high. Now let's see a pattern. Hopefully you're starting to get it. The high thyroid hormone will have a low TH because if there's too much hormone in the system, there's no need to have a high TSH because there's too much hormone, right? That thyroid stimulating hormone. A low thyroid hormones, that T3, T4, you will see a high TSH, a high thyroid stimulating hormone because there's not enough thyroid. So that T3, T4 is low. So the body's saying, hey, we need to crank up that the body, the TSH, to create those thyroid hormones. And why is because, I guess what I'm explaining to you is a negative feedback. If one is too high, the other is too low, and vice versa. If one is too low, the other one is too high. The NCLEX is not going to probably say that the patient is having a thyroid storm or they have myxedema coma. You just have to know the labs. And that's why it's so important to know those labs, to know the lab values, and what do the labs actually mean. Okay. Now, how would your patient present? What would they look like when they come to you? And this is really, it tells the NCLEX, it tells your instructors if you're a strong test taker and clinician. So in with a thyroid storm patient, that patient may present with high fever, tachycardia, hypertension. Remember, everything is the metabolism's running high, agitation, delirium, um, maybe going into coma, maybe, nausea, vomiting, diarrhea. Remember, the patient looks as if they're overheating, overworking, overstimulated. On the other hand, the patient with myxedema coma, they'll have hypothermia, so they're cold, bradycardia because the metabolism is slow, hypotension. They'll have lethargy going into coma, slow respirations that would lead to respiratory failure. The patient looks as if the body is shutting down. So the trick, I'm saying it again, I like to repeat things. In a thyroid storm, hot, fast, and agitated. In myxedema coma, cold, slow, unresponsive. If you remember those patterns, you should already know the answer. So what actually is killing your patient with these two conditions? So you really have to think like a nurse here. Think like the NCLEX. Let's say it like that. Let's think like the NCLEX. In thyroid storm, there is a cardiac overload. Everything is overstimulated. Remember, you had the hypertension, you had the tachycardia. So that cardiac overload will lead to arrhythmias and possibly cardiovascular collapse. On the other hand, myxedema coma, you have everything is slowing down, remember? So they're having respiratory failure. They're having those slower respiratory rate leading to respiratory failure along with a decreased metabolism. And that will lead to death if it's not corrected. So thyroid storm, there's a cardiac emergency. Myxedema coma, there's a respiratory and metabolic shutdown. So how are we going to care for these patients? What's the priorities? Okay. So in the thyroid storm, the priorities are to reduce the thyroid hormone effects. You know, we know that everything is revved up and overstimulated. So you'll see orders for beta blockers. That would be to control the heart rate. And you're going to also monitor for any cardiac arrhythmias. You may see orders for anti-thyroid medication, either PTU or methimazole. And so that's to or anti, so it's to kind of block the thyroid from producing. You'll see cooling measures like cooling blankets. Why? Because everything is overstimulated. Sorry, the metabolism is revved up. So you'll see cooling measures like cooling blankets. You'll see orders for IV fluids. Remember, you must slow everything down on this patient. The thyroid storm is just revved up too fast. And so you're going to see orders to slow everything down, bring everything down on this patient. With myxedema coma, the biggest thing is airway and breathing support. We're going to even look at aspiration precautions. Remember, the metabolism is slowing down, the body is shutting down. The patient may need oxygen, possibly even ventilation. You'll see orders for IV thyroid hormone, like levothyroxine, because they don't have enough thyroid hormone. So you need to replace the hormone that's missing in their body. You're going to see warming of the patient because everything is shutting down. The patient is cooling down, so you need to warm them up. You're going to monitor blood pressure because they're going to have hypotension. Remember, you must support the patient and speed things up safely. So if on the NCLEX, one question is, the patient needs warming, you should say, okay, well, that's myxedema coma. And if it asks, a patient needs cooling, then you should say, okay, well, that's the patient going through thyroid storm. Now, what kind of traps are you going to see on the NCLEX? You want to avoid mixing up high versus low hormone. Okay. You want to not miss the temperature cues. Person revved up, metabolism revved up, that should be thyroid storm. And then the opposite would be myxedema coma. You're going to ignore heart rate differences. Tachycardia with your thyroid storm, bradycardia with your myxedema coma. Um, and a trap would be, you're treating all of these symptoms, the cooling blankets, the warming blankets, uh, fluids, but you're not fixing the underlying problem. Not saying that you have to, but you have to be your patient's advocate. And if you notice you're getting all these orders, but things to correct the thyroid issue, you don't see orders for those, you need to advocate for your patient and say, hey, we're doing all this, but we need to correct it so it can stop. So the NCLEX will give you like vital signs, they'll give you labs, they'll give you symptoms, and you are expected to recognize the pattern. It's always a pattern. So let's recap. In thyroid storm, you have a high T3, T4, a low TSH. They're hot, they're fast, everything's going fast, they're agitated. You'll see tachycardia, fever, and they'll need cooling. So you'll see the cooling blanket and they'll need medications. Now, with the myxedema coma, they'll have a low T3, T4, they'll have that high TSH. They're cold, slow, and unresponsive. They'll have bradycardia and hypothermia. So they'll need warming and they'll need to replace that thyroid hormone that's missing. So remember, thyroid storm, hot and fast. Myxedema coma, slow and cold. So hopefully now you understand, those thyroid emergencies. We've, officially covered like the most important endocrine criticals. If you haven't seen them, please go back and look at DKA versus HHS, SIDH versus diabetes insipidus, Addison's versus Cushing's, because together, this is how you're going to master endocrine for the NCLEX exam. And so that's it. Like I said, hopefully this finally helps you understand those two endocrine emergencies. If you like the video, please subscribe to NurseEdScholar. Save this for your exams. Come back, look at them again to refresh your memory. Because here we don't memorize. You know, we're trying to teach you how to think like the NCLEX, how to get you ready for clinical practice. So I'll see you in the next one. And happy studying from NurseEdScholar.